Thank you very much it's been good to be here after a hiatus of 30 years. The talk that has been given is it's not started yet. Okay, non-invasive multimodality imaging in coronary artery disease. It's a huge topic and I'll try to stick to 20 minutes. I've deleted a lot of slides here. Basically, the outline of the talk is what is multimodality imaging here, the role of non-invasive MMI in the diagnosis of CAD. We discussed the nuclear cardiology, SPECT and PET, coronary artery calcium scoring, briefly CT coronary angiography, echocardiography and cardiac MRI, briefly the appropriateness criteria because of the paucity of time given, and then conclude the talk. I hope to do it in time. So what is multimodality imaging for the evaluation of CAD? It could be hybrid or fusion imaging, interpretation of two images of different modalities for cardiac imaging side by side through integration of function and structure, morphology like CT angiography in a single procedure, or it could also mean the clinical role of the different current non-invasive imaging modalities in the diagnosis of CAD. You can take what you want, whether they are hybrid or they are side by side, it's still the same. What it does is increases the diagnostic accuracy and efficacy of the coronary artery disease diagnosis and allows assessment of the functional consequences such as myocardial hypoperfusion on SPECT or PET, of anatomical pathology such as coronary artery stenosis. Non-invasive cardiology imaging started with nuclear cardiology first, which is currently SPECT and PET. There is echocardiography, calcium scoring, cardiac CT, cardiac MRI, and ultrasound. So nuclear cardiology started with the advent of the gamma cameras, the angiogram camera, and then we had the myocardial blood pool traces labeled RBCs and HSA, and we went in the 1970s through the introduction of the myocardial perfusion tracers, and this is one of the initial examples of what we used to do here in the Nuclear Medical Center in AFIP, thallium-201 scan, normal with left ventricular hypertrophy, and blood pool imaging using technetium albumin scan. So over the years, the nuclear cardiology evolved with the advent of single photon emission computed tomography. We had pharmacological stress agents, and then the technetium agents came in, and we started having gated acquisition and with improved counting statistics, etc. So currently, non-invasive cardiac imaging is SPECT and PET, gamma cameras and PET cameras, and they allow myocardial perfusion imaging allows cardiac stress testing, exercise or pharmacological. We have gamma cameras as well as PET now, and for quantitation we can quantitate perfusion and function to diagnose ischemia infarction and myocardial viability and also detect cardiomyopathies. So SPECT myocardial perfusion scan, as you know, HLA, short axis and VLA, and this is an example of LAD ischemia pre-stenting and then post-stenting. Just a few examples very quickly. This is a fixed perfusion defect. This is an LAD infarct. Here is a fixed perfusion defect in the inferior wall, inferior MI, and as we well know, the Achilles heel of our nuclear cardiology screening short of PET is the balanced ischemia when we cannot see a relative difference, and that is our Achilles heel. We can discuss non-ischemic, we can actually diagnose non-ischemic and ischemic cardiomyopathies. And now, in recent few years, we have now SPECT CT cameras. They are 16 slice and even increasing, which allow us, in addition to the myocardial perfusion imaging, we can do SPECT CT imaging for attenuation correction, which is really very nice, as well as coronary artery calcium scoring using the SPECT CT cameras, and with the PET we can of course do further up. This is something I did 3-4 days ago. You can actually look at your myocardial perfusion scan with the SPECT CT scans and actually look at the low resolution images to do incidentalomas, and also look at a picture of qualitative rather than quantitative picture of calcium scoring. So just show you an example. I was looking at this and I looked at the CT part, and you can see a breast mass here on the left side, and which also has MyoView uptake, and then we put that in our report, but nobody did anything about it because they were not really interested. And 2 years later, the patient come up with this sodium fluoride scan with multiple metastases. So it is important to look, if you have done even a low quality CT, to look for something else that may be hidden there. It is done, it is there. It may be not diagnostic, but you may actually find something that is of importance. I also look at always these raw images to see if there is absent gallbladder activity, to look for gallbladder problems. And here we don't see any gallbladder activity, and then we look at that and we have a stone in the neck of the gallbladder. So interesting. Similarly, another one I showed, there are pulmonary nodules in a 48-year-old female with atypical chest pain. MPI is abnormal, but the CT component shows pulmonary nodule that turned out to be sarcoidosis. It's useful to have a look at the CT component anyway. So with the cardiac CT, we can do calcium scoring as well as cardiac CT angiography. The basis of calcium scoring is basically calcium scoring helps with the traditional risk factors, age, cigarette smoking, total cholesterol, etc., and you divide them due to the systolic blood pressure, etc., into low, intermediate, and high risk group. And what the calcium scoring does, the risk category determines the therapeutic intervention and the lifestyle changes and target the LDL goals. Traditional risk factors, however, only predict 50 to 80% of the cardiac risk, whereas the calcium scoring helps qualify the conventional risk analysis and is appropriate for risk assessment in asymptomatic patient at that stage. So you can visually assess the calcium score. There is no calcification, mild to moderate calcification, and severe calcification. The prognostic value of coronary artery calcium is that the survival is proportional to the degree of calcium scores or coronary artery calcification. The facts are that coronary calcium is a surrogate marker for coronary atherosclerosis. It provides cardiac risk stratification with a low radiation dose, and basically if the calcium is absent, it is a very low risk, less than 2.5%. The role is to screen patients with moderate cardiac disease. Positive calcium indicates an incremental risk. It alters the therapeutic goals and identifies patients who do not need any further evaluation and can be used as an ongoing management tool. So now we come to PET imaging. We have discussed that in the workshop yesterday, so I'm not going to go too much into it. For perfusion, we use rubidium, oxygen, and ammonia, and for viability, we use FDG. There are several technical advantages of PET over SPECT, and these are accurate depth-dependent attenuation correction, high spatial resolution, high temporal resolution, and we have tracers with higher extraction fractions and shorter half-life, and the results are less equivocal and the image quality is much, much superior. Example of a ammonia PET normal myocardial perfusion image, normal cardiac rubidium PET, and an abnormal cardiac rubidium PET MPI with infralateral wall ischemia, as you can see as marked by these arrows here. So when you compare PET with SPECT, here we are, the PET has an overall, PET is more sensitive with higher accuracy and less artifacts. PET quantification is a new thing, and it allows quantification of both the myocardial blood flow and the coronary flow reserve, and this is really very important in differentiating the macrovascular coronary artery disease from microvascular coronary artery disease. Abnormal flow reserve in regions with angiographically normal territories in patients with coronary artery disease depicts early functional vascular abnormality, which has changed the traditional paradigm of using the MPI for diagnosing obstructive coronary disease to detect patients who are at risk of developing coronary artery disease and detect patients who have preclinical, not yet obstructive coronary artery disease. Next, we come to echocardiography very quickly. We have dobutamine stress echocardiography as myocardial contrast echocardiography, and this is left ventricle at different stages of dobutamine stress echocardiography. And here you can see anterior wall showing abnormal velocity response, which coronary angio shows significant LAD stenosis. Myocardial contrast echocardiography is based on the detection of two basic components of perfusion, the myocardial blood volume and the capillary level and the rate of flux of that volume through the tissues. These are the examples. Here is a normal scan, and we have reversible ischemia on the second image, stress and rest, and a fixed effect on an infarct, which hasn't. So it is, however, the MCE hasn't reached its potential because the contrast agents are not available, there is no expertise, and no reimbursement. Now we come to the cardiac CT angiography. You can see the exquisite quality images, and it is used for a diagnosis of lot of pathologies, but the triple rule out of coronary angiography, you can look at the aorta for aneurysm and pulmonary embolism, all three in one go in one case. So this is an example of normal coronary arteries, and you can see here the stenosis, and look at the beautiful resolution here. So it not only gives you the luminal narrowing, but it also gives you the plaque burden, which cannot be diagnosed through the conventional invasive angiography, and you can see it here. So we also, there is a what you say auto-regulation when there is plaque, where is narrowing a coronary artery, then auto-regulation, other mechanisms come in to dilate the vessel at that time, and that cannot be detected by invasive angiography. However, in here you can actually detect, here we see the plaque as well as the fact that there is no significant stenosis. So in that case it is better. The other thing that it is very good at, it is to getting and diagnosing coronary vascular anomalies, which cannot be detected by invasive angiography in most of the cases. Now we come to the cardiac CTA rule, and it is a diagnostic tool with a high negative predictive value. It adds incremental diagnostic and prognostic information, and it's probably better in the lower risk patients with the CAD, whereas SPECT may be better in patients with a high pretest likelihood. So when to refer a patient for cardiac CT? When it is low, you don't do anything. When it's high, proceed to invasive coronary angiography. When it is moderate to high, you go for the perfusion scan, and you go for a CT angiography when it's low to moderate. Now we also have hybrid PET-CT with CT part component which can detect atherosclerosis with functional significance of that particular lesion provided by PET or SPECT. And now you see a normal RCA here, and we can reconstruct it various ways. And here is a very tight stenosis, which you can see with the arrow in the LAD, and the effect of that stenosis on the myocardial perfusion, which you can see on that hybrid image. Cardiac MRI, this is an example of a normal perfusion CMR and abnormal perfusion study in a patient with left main stem disease. And then this is an example of a contrast MRI, inferior MRI 6 days post contrast enhancement, and an anterior MRI here. So the advantage of cardiac MRI are multiple, but it has been very slowly accepted into the clinical practice. Coming to the appropriateness criteria of various investigation, what is an appropriate imaging study where the expected incremental information exceeds the expected negative consequences of that particular imaging modality? So score 7 to 9 is appropriate for a specific indication, scores 4 to 6 are uncertain, and 1 to 3 are inappropriate. Here, CT angiography, being the first imaging modality, is used for moderate pretest likelihood of CAD less than 50%, and for stress echo is appropriate for the initial diagnosis when there is change in the clinical status, but is not appropriate for routine testing. So basically, when you do one test and it's equivocal, you switch to the other test. So when the myocardial perfusion imaging is equivocal, you do a CT angiography. When the CT angiography is equivocal, you go to the sister imaging modality. So here we are in summary: chest pain syndrome, CT angiography. When it is low to intermediate, do it. When it is intermediate to high, you can do stress myocardial perfusion imaging, stress echo, or dobutamine MR. For the assessment of cardiac function, echocardiography. For the assessment of myocardial viability, you can do cardiac MRI when and where it is available. So my concluding message is, there is no simple recipe. You should appropriately use all of the available technologies if they are available to you according to the clinical need and keeping in mind the appropriateness criteria. Thank you very much.